Well, hello to whoever is watching this. This is our information session for the Metformin and CP clinical trial, which is being run at Holland Bloorview Kids Rehab Hospital and the Hospital for Sick Children, both in Toronto, with our co-principal investigators, Dr. Darcy Fehlings and Dr. Donald Mabbott. So this session is to give an overview of the background of why we're doing this study, why we think it's important, and why we think it's interesting and a great study for families to participate in. And then we've also got some frequently asked questions that we will get to towards the end of the presentation. To start, what I want to do is just introduce those of us who are going to be speaking on the information session today. So first up will be Dr. Donald Mabbott, who is our co-principal investigator and the lead investigator at the Hospital for Sick Children site. And he's a psychologist at the Hospital for Sick Children and a professor at the University of Toronto. We also have Dr. Darcy Fehlings, who is the lead site investigator at the Holland Bloorview site. She is a developmental pediatrician and also affiliated with the University of Toronto. Myself, my name is Daniel Warner. I'm a clinical research coordinator at Holland Bloorview Kids Rehabilitation Hospital. And we also have Cynthia de Medeiros, who is a clinical research project manager at the Hospital for Sick Children. So myself and Cynthia sort of take care of a lot of the day-to-day and on-the-ground aspects of the study. What I want to do now is I will unshare my screen and then throw it over to Dr. Mabbott, who can start our presentation.
Thanks, Daniel. So really, what we want to do today is give families information about this trial so that you can make a decision about being interested in the trial or not. How we're going to divide it today is I'm going to give a bit of the background, some of the basic science. I'm hoping to give it in a manner that is accessible, and that should be easy for me because some of the basic science is over my head. So I should be able to communicate it in a manner that makes sense, because if I don't, it's because I don't understand it. And then I'm going to tell you about a pilot trial that we've done at the Hospital for Sick Children using metformin in a different population of children with brain tumors who are survivors of brain tumors. That gives us a bit of insight into how metformin can be used to help with motor recovery and brain repair. And that is where then Dr. Fehlings is going to talk about the specific trial that is shared between Holland Bloorview and Sick Kids, where we're looking at metformin in children with cerebral palsy. So what I'm showing you on this screen is some cartoons of the human brain on the left side. I think it's the left side. It's on the left side on my screen. And the mouse brain on the opposite side. And the brain has stem cells in it. So actually the whole body has stem cells in it. Stem cells are these immature cells that can grow into any type of body tissue in the body. They're essentially what our bodies grow from when we are in neonatal development. And there are certain places in the body where these stem cells continue to reside, continue to live. A good example is the skin, is the dermal cells. We have dermal stem cells so that when you cut yourself, for example, and then the skin heals, that's because of the stem cells that reside there that grow into healthy, normal skin cells. It turns out the brain also has these stem cells. The stem cells in the brain are already, they can only turn into brain cells. It's not like you could take them and turn them into skin cells, or it's not like skin cells you could then implant in the brain and turn them into brain cells. They're already, we say their cell fate has already been set. And so we call them neural precursor cells. Neural meaning brain, precursor meaning precursor, and cells. And they live in a few places in the brain, and we know this originally from looking at the mouse brain. So I'm going to show you this here. This, and you're saying to me, well, how is this a brain? Well, imagine a mouse head is cut along the longitudinal axis, and the ears are on the sides, and the nose is up here, and the back of the head is here. There's an area in the brain called the subventricular zone, which basically means beside the ventricles, which are the fluid-filled cavities in the brain, where stem cells live. And these stem cells grow into, they multiply, and then they grow into regular neurons, regular brain cells. They migrate down this pathway to this area of the brain here. This is the olfactory bulb, the smell sense, the smell center of the mouse brain, and they grow into olfactory neurons. Neurons important for smell. And why we think this is important in mice is because smell is so important for their memories. There's another part of the mouse brain. So here's again a different picture of a mouse brain. Now it's flipped. So now the front, the nose of the mouse is over here, and this is the back of the mouse. There's an area in the hippocampus called the dentate gyrus. The hippocampus is that part of the brain that's important for memory. And the very unique thing about the hippocampus is that's also a place where these stem cells reside, where they live, and they grow into, they multiply, and they turn into, they differentiate is the term that we use, into healthy neurons, healthy brain cells that are important for memory. And so we've found since that actually these same areas, we call them niches, exist in the human brain. So here is the subventricular zone in the human brain where stem cells reside. And then there's another place where stem cells reside. So this picture of a human brain now is as if we were to cut my brain in half like this. And so the nose is sticking out of the front of the screen to you, and then the back of the brain is into the screen, sorry. And there's this place called the subventricular zone where stem cells reside, and they multiply and they can grow into healthy neurons, healthy gray matter. But also there's an area in the brain, the subcortical white matter. So the white matter in the brain is the insulation in the brain. It's the insulating insulation of all the connections in the brain. That's another place where stem cells reside, and they can grow into white matter. And finally, here's an inset of the hippocampus. So again, in my cross section of the brain here with the nose coming out, this is where you'd find the hippocampus, that part of the brain important for memory. And here, this red line is the dentate gyrus. That's where these stem cells reside, and this process of neurogenesis, neurobrain genesis creation, where these new brain cells, gray matter cells are created. And we know that this process is critically important for memory. So we have stem cells in the white matter, and we have stem cells in the hippocampus. And we think we can harness these stem cells. We think we can turn these stem cells on to help repair the brain. Dr. Fehlings will tell you more, but for example, in children with cerebral palsy, one of the areas of the brain that can be damaged is the white matter. So what if we could regrow white matter from these stem cells? That could have a profound impact for children and potentially even adults, because this is a regenerative reparative process. These ideas really, I think, were started by Dr. Frieda Miller. She did a lot of the basic science work. Anytime you do a clinical trial, there's a lot of foundational work that's been done behind the scenes, as it were. And I think if any of you were following, say, the development of a vaccine for COVID-19, you would know that very early on, they did these animal studies to make sure that the vaccines were safe and effective. And essentially that's what we're talking about here. But the first thing that Frida did was find out how exactly does metformin turn on the stem cells in the brain. And she found it turns on this pathway that I always have a hard time saying, and so don't ask me how it works, but it's the atypical PKC-CBP pathway. And this pathway is how metformin turns on the stem cells to grow into neurons and to grow into in the brain. Now, you know, why did Frida even think about looking at metformin? Well, this is a kind of the cool serendipity of science. She was talking with a friend and a colleague who looked at the effects of metformin in the kidneys. And there's a similar pathway there, and because we know because of its impacts for diabetes. And he said, well, you know, this pathway works, metformin works on this pathway. And she said, well, I know this pathway actually also works on stem cells in the brain. Maybe metformin will work on the brain. And so she did a study with her postdoc, Jing Wang, where they used a transgenic mouse model. That's just a big word for a genetically modified mouse. And so here's my mouse here with their, where they modified the brain of the mouse so that it can light up and stem cells can actually be imaged after the mouse has been sacrificed, and they look at slices of the mouse's brain. And we see here, so this is now the dentate gyrus of a mouse brain. So again, this is the hippocampus. You know, the mouse's brain would be much bigger, but this little area is this hippocampus. And all these areas of green are neural precursor cells or brain stem cells. And this is in a control condition when the mice were not treated with any metformin. Now look over here, you'll see this is a dentate gyrus of a mouse treated with metformin, and there's many, many, many more stem cells. All these areas of green, if you count them up, it's statistically significant. Here is an image of the neurons that these stem cells grow into. And you'll see, just visually, you can see there's many more neurons, healthy healthy gray matter in mice treated with metformin compared to mice treated with a placebo, essentially. And she also found that these mice who were treated with metformin had better memory, which is very cool. So it's this idea that you can use metformin. It's going to expand the stem cells. It's going to help them multiply. They're going to migrate, and they're going to differentiate, which is a big word essentially for maturing into neurons, astrocytes, which are part of that white matter that I told you about that insulates the brain, and glial cells, which is also part of that white matter. And so with this in mind, Frida, along with myself, along with Cindy Morsehead, along with Eric Buffet at the Hospital for Sick Children, said, can we look at metformin to help with the injury that children who have been treated with brain tumors have from their curative radiation? And we looked at it in parallel between both another mouse model. This time these mice had an injury from radiation, and in a group of children who were treated for a brain tumor. So children who are treated for a brain tumor, which you see here, so again, here's an MRI, and here's the front of the head, and here's the back of the head. Here's the brain tumor here before it's been resected in the child. You can see this brain tumor here, and then we treat children with radiation and chemotherapy. All of these things, the tumor, the surgery, the radiation, and the chemotherapy can result in an injury to the brain. And we want an injury to white matter and an injury to the hippocampus, the two areas where stem cells live. And so we wanted to determine, could we use metformin to mitigate, to help the brain recover from an injury, both in a mouse model and in a pilot trial in children. So this is the mouse model that is essentially what Cindy did. So again, she took that transgenic, that genetically modified mouse, and when it was 17 days old, these mice, it's a group of mice, were treated with radiation to the brain. And then she essentially extracted some of the stem cells from different parts of the brain and put them in a petri dish and grew them. This is called the neurosphere assay. And then some other mice were treated with metformin now from when they were 18 days to 42 days old. This is roughly equivalent with early to middle childhood in humans. And then she tested these mice with some different cognitive tests. And then in another subset, she did another neurosphere assay to look at the stem cells. And this is what she found. So in the control mice who were not treated with any metformin, were with placebo, here again, you see this time the stem cells are lighting up in red. When they treat with radiation, you see that radiation damages or depletes the stem cells. The stem cells die off. And there's reasons why that would be, but I won't get into it. But when these mice were treated with radiation, the cells multiplied and actually recovered, when they were treated with metformin and radiation, the metformin helped the stem cells recover back to the same levels as the control mice. And this was actually also seen in mice thinking abilities. This is a Y maze. So a treat is put on either arm of the maze, and the mouse walks along and explores and finds the treat, and then the treat is removed. And then you measure how many times they go and make the right choice to where the treat was. And you'll see in female mice, here, they were accurate about 60% of the time, but after radiation, their performance got worse. But it was rescued when in the mice that were treated with metformin. So their memory ability was improved back to almost normal levels when metformin was treated. Now, interestingly, we only saw that effect in female mice. There was no effect of metformin in the male mice, which I think will be important when we start thinking about the human trials, because perhaps this suggests that maybe females might be better benefit from metformin than males. So then we said, let's look at this in a population of children. And we can do that because metformin is a well-known drug. It's been used, as we've mentioned, in diabetes and in metabolic disorders, since 1959. Its safety profile is well known. It's been used in children as young as 2 years. And actually, there's some literature that shows that metformin can actually improve thinking skills in adults with degenerative disorders. And we wanted to, first of all, say, okay, well, is it safe to use in children treated for brain tumors? And can we find a target for a future trial? Can we find the place that we want to look at in terms of the thinking abilities to help design a phase 3 trial? So this was a pilot trial, a early phase trial. And again, I'm sure from watching the vaccine development, these early phase trials are only intended to be building blocks for the final phase 3 trial. And that's all I'm showing you here. We wanted to use this to inform a later trial. This was work done by Rami Ayoub, a master's student in my lab, and certainly Eric Buffet, who's the head of the neuro-oncology program at SickKids, was very helpful. I'm not going to spend too much time because this is a very active slide, but basically we looked at 130 patients to see who was eligible or who wanted to participate, and of that we had 24 patients. And so you'll hear from Darcy that the recruitment for our CP trial is maybe a bit slow, but it's not unexpected because we experienced the exact same thing. It takes a while for people to start doing these new types of trials. But what we did is, one group, we gave them metformin, and then after a washout period where they didn't have any metformin, we gave them a placebo. And then in another group, we did the opposite thing. They were given a placebo and then a washout so that the drug would leave their system. In this case, it was a placebo. And then they were given metformin. And we looked at their blood work to make sure there was no adverse effects. We looked at their report of any issues they may have had. We looked at how well they adhered to the study. And we looked at a number of thinking measures of memory and attention. And we looked at some neuroimaging measures of the white matter in the hippocampus because of the reasons I told you earlier. I'm not going to go into this imaging stuff today because in the interest of time, I just wanted to show you some of the safety findings we had and the memory findings that we had. So we found that metformin is safe and feasible to use in survivors of pediatric brain tumors. So the biggest concern with metformin is a adverse effect called lactic acidosis. And Darcy can tell you more about that. But we saw no evidence of lactic acidosis in any kids in our study. And it's a fairly rare occurring adverse effect, and we didn't see it. What we did see are some minor gastrointestinal effects like vomiting, diarrhea, nausea, stomach pain. But you'll see actually also that these were also the most frequent things seen in our placebo group. Each one of these colored bars represents a single individual in the study. But no individual decided to leave the study because of these adverse effects. They were manageable. And these are things that we know typically happen in people treated with metformin. The cool thing, from my perspective, was when we looked at their memory ability, and this is just two different measures of memory. I won't go into the details. The blue line is the people treated with metformin, and the orange line are the kids treated with placebo. You see that the memory abilities increased during treatment with metformin. We also measured how quickly they did a number of thinking tasks. And again, now the speed with which they did those tasks decreased. They got faster over time on treatment with metformin compared to placebo. Now, I'll highlight the fact that these are really small numbers. So like this, for example, is in 3 kids versus 5 kids and 4 kids versus 4 kids. So this is very preliminary pilot data. This is not to say metformin works. It's to say that metformin is worth pursuing in a bigger trial to see if it works. But the fact that we saw the same effects on memory in the mouse studies, where we know the actual mechanism, we can see the growth of the stem cells, and we see the same thing in the human studies, is encouraging for us. So I think we showed that metformin is feasible, it's tolerable. The synergy of findings between the animal studies and the human studies is very intriguing and exciting, but this is a very small pilot trial. I keep saying that because we can't get ahead of ourselves. We have to follow the procedures to make sure this really works. And we actually now have a larger trial funded in Canada and Australia to look at metformin in children with brain tumors. And so finally, I'm going to switch gears a little bit because this is a trial about cerebral palsy, to talk a bit about the background as to why we want to look at metformin in cerebral palsy. So the brain tumor work was essentially to make the case to you that this is worth pursuing, it's safe and it's feasible. And now let's try another population of children who've had a brain injury. This time, it's a different brain injury. It's a brain injury associated with early adverse outcomes. But it also has an impact on white matter. So Cindy Morstead, my colleague who did the mouse work in the brain tumor stuff, has also looked at a mouse model of hypoxia ischemia, which is essentially you could say is a mouse model of childhood cerebral palsy. And she did a similar type of study where now in very young mice, now about 9 days old, she gave them metformin for about a week. And then she did a number of assessments of behavior up until about 23 weeks. She did the same staining, staining to look at stem cells in the brain, and here's in the corpus callosum. And she saw that treatment with metformin, this is the contralateral and ipsilateral, essentially all you need to care about is these dark lines here showing that with metformin, there was many more stem cells, new stem cells in the corpus callosum in the mice with the hypoxia ischemia injury compared to mice who were treated with a placebo. Really cool was the fact that she saw motor recovery. So she did what is called a cylinder test. And after a mouse is given a hypoxic ischemic injury, it has a hemiparesis. It can't use one of its paws well. And we know from cerebral palsy that you see the same types of motor difficulties. And so the mouse is put into a cylinder to explore that cylinder, and you look at how much it uses both paws versus one paw to see a measure of its motor function. And so if you look here, the non-impaired four-paw preference percent, which is essentially how much they use their good paw, you see it's very low in the control mice. They're using both paws. When you give them only metformin, it really doesn't change anything. But after the hypoxia ischemia injury, now they are using only that non-impaired forepaw because they are unable to use the other paw. But when you give them metformin, they're back to the same level as the control mice. So we've rescued motor function, Cindy rescued motor function in these mice, which I think gives us that much more basic science evidence and encouragement to now take metformin into a human population who have motor challenges, and that is children with cerebral palsy. And with that, I need to acknowledge the people in my lab who did this work. So there's Cynthia there. You're going to hear from her later. Jovenka did a lot of the imaging work. I need to also just mention the people that helped fund this work. And they're those people. 3-B, who many of you know, funded a lot of the early basic science work. And with that, I'm going to stop sharing my screen and pass the talk over to Dr. Fehlings, who's going to now tell you about the trial of metformin. Again, it's a feasibility trial a phase 2 feasibility trial that we are conducting right now in children with cerebral palsy.
So I'm really happy to talk a little bit about our metformin study in children with cerebral palsy, which is a feasibility study and really builds on all of the great work that Dr. Mabbott has just shared with us. So I'm just going to provide a high-level project overview. So our main objective for the study is to answer the question, does metformin help to improve movement skills for children with cerebral palsy? And it's a randomized controlled trial, and it's blinded. So it's our strongest study design. And we're dividing the children who are participating in the study into 2 groups. So both groups receive physiotherapy, and then approximately half the children will receive metformin, and half the children will receive placebo. And we get outcome measures before we start the therapy and then after, and see if there's been a change in our outcome measures. So our study goals, is this a feasible study? Can we run the study the way it's been designed? And we've heard from Dr. Mabbott that he was able to complete a study in children who had had radiation following a brain tumor. But we want to see if we can do a study in children with cerebral palsy. We also are looking for signal. So what do I mean by signal? We're looking for any evidence that metformin may be contributing to either improved movement in children with cerebral palsy or improved cognitive abilities. We're doing imaging to see if there is a change, whether we can see any change in the structure of the brain. We're also looking to see if the extra tone that children with cerebral palsy have can be reduced. If metformin is acting by helping white matter, one of the things that we would see on neurologic examination is a reduction in that extra spasticity or stiffness that they have. And then importantly, any trial that we do that involves individuals should really relate to individualized goals that are important to the child and the family. So we're also measuring any change in those goals before and after the therapy. We're measuring quality of life, and we're doing looking at some cost studies as well. So who are we trying to recruit into the study? So we're focusing on children who are between the ages of 5 to 13 years. And the reason we have a younger age group is we want the children to be able to actively participate in the therapy, but also complete the outcome measures that we have, particularly the cognitive outcome measures. And then the upper age of 13 is just set so that we can focus our efforts so we have less what we call noise in our outcome measures and more chance to detect a signal. We want the children to be diagnosed with cerebral palsy and that there is spasticity present in some form in both legs. And this really relates to some of the earlier brain images that Dr. Mabbott showed, where the stem cells that are inside all of our brains are sitting in this area that is very packed with white matter. And this particular injury pattern of having evidence of the white matter injury leads to spasticity in both the legs. It's also seen in children who are born prematurely, so that's why we put the premature birth in. And we have made a request that the children be functioning at a gross motor function classification level between 2 to 5. And so what the gross motor functional classification level represents is the severity of the physical disability. And a child who is functioning at level 5 is a child who's mobilizing in a wheelchair, and a child who's at level 2 is mobilizing by walking themselves without a walker. A child who's at level 1 is at a very high level of gross motor function. And the reason that we're not recruiting children who are level 1 is that we may not see enough of a change in motor performance. So again, it's trying to increase our chance of detecting a signal with the metformin. Importantly, we want the children to be medically stable. And there's a whole bunch of criteria that I haven't listed here around medical stability. But it's important that in this early feasibility study that we try to maximize the metformin use safely in children with cerebral palsy. The Band-Aid sign, it says evidence of a white matter injury, and this is on an image that the child already has had ordered clinically, so we don't require them to get another brain picture. But again, we're looking for that white matter injury pattern because of the information that Dr. Mabbott shared about where the stem cells reside and how close they are to the white matter. And then we check blood tests to make sure that the biochemistries are good so that they have a very low risk of taking metformin. What are our outcome measures? We're definitely looking at safety. We're looking at adherence. The green box represents our motor outcomes, and we're using our main motor outcome called the gross motor function measure. And it's a gold standard measure looking at big movement function in children with cerebral palsy that studies around the world use. And it's an important outcome measure because we know that it's responsive to change if a change in motor performance has occurred. We're looking at cognitive function, And then we're measuring quality of life and well-being and costs. So what does it mean to take part in the study? It's a 10-month commitment, which sounds like a lot, but the first 16 weeks are the one that's the most time intensive. So the physiotherapy sessions are twice a week, and we have the child participate in the physiotherapy sessions over a 16-week period of time. And then we do outcomes at the beginning, after the 16 weeks, and again at 6 months. So most families are really pleased to hear about physiotherapy because they would like to get extra physiotherapy. And so this is a very active physiotherapy session where the child sets goals at the beginning and then works with the physiotherapist individually for 45 minutes each session, 2 times a week. And then we ask that the child with the family and parents do some practicing at home for 30 minutes a day. Now I wanted to talk a little bit about the side effects, and Dr. Mabbott has presented information on some of the side effects that they saw in children who had the brain tumors. And the most common side effect are gastrointestinal or tummy side effects. So diarrhea, vomiting, some abdominal pain, indigestion, gas or bloating, a stomach ache. And within the study protocol, if the child is having some GI symptoms, we can adjust the dosage. And we also build up the dosage very slowly to try to minimize these effects. You can also get a bit of an unpleasant taste in your mouth. And then the less frequent side effects are just feeling fatigue, loss of strength, some headaches, lightheadedness, shortness of breath, sneezing, flushing of the skin, irregular heartbeat, rarely a vitamin B12 deficiency. So we encourage all the children in the study to take a multivitamin to avoid that. Usually the side effects are mild, but there is a severe side effect called lactic acidosis. And we screen for any evidence of increased lactate at the beginning of the study. And we also screen for any past history of any metabolic acidosis problem, again, to really try to minimize that. It's a very rare side effect. In terms of where we're at with the study, we have Health Canada approval, we have REB approval, and we have 1 child enrolled to date, and we're aiming for 50 children. I just wanted to mention briefly that the study has been funded through ChildBright, and we have a very active stakeholder engagement committee that helps to guide us in the trial. And I have 3 of their pictures here, and then 2 more pictures here for our stakeholder engagement. So I'm going to stop sharing now, and we can move to some questions.
Great, thank you so much, Dawn and Darcy, for all the incredibly interesting and informative information. So before I move on, we have some frequently asked questions that we are often, I'll turn on my video so you can all see me, that we often encounter during our recruitment process when we speak with families. Before I get to those, I know we have some members of our stakeholder committee here, so if anybody on that committee has any questions, just thought I'd open the floor to you guys first, and then if not, we can move on to our frequently asked questions.
Yeah, Darcy, if I may, as you know, I am among the converted supporting your study, but just other than saying hello to the viewers of the future from the presenters of the past, if I were one of those people, I might like to have a little more information about a few slides ago when you mentioned that both the treatment arm of the study and the placebo arm are receiving physiotherapy, you mentioned a little bit about the standardization of those measures in terms of frequency and duration, but has anything specific been done in terms of the actual physiotherapy treatments or exercises so that we can, as best as is possible, hone the variables that might be attributable to the intervention rather than any robustness of the physiotherapy?
Yeah, thank you for that question, Kent. So I'm definitely really happy to elaborate on that. We have an excellent physiotherapy team, and there's a physiotherapy manual that has been developed for the study to try to standardize approaches amongst the team. And then each child is paired with 2 therapists so that you can get that bond happening between the child and therapist. And the principles of the physiotherapy are everything that we know now that we know helps to make physiotherapy work. And it really falls under the broad umbrella of being active motor therapy and motor learning principles. So this is where it's like a whole goal is approached, and it's sort of like eating a whole food rather than parts of a food. You're working towards an activity or a participation activity that is meaningful to the child. And then the therapist will support the child in working towards that important goal, and then help to do some repetitions and practice to consolidate the goal. So there's these broad principles, and then we have quite a broad spectrum of children participating in the therapy, and it's really important that the therapy is meaningful for the child. So what we've done within the sort of the therapy manual is built up some suggested potential activities for each of the gross motor function levels. So level 2, level 3, level 4, level 5, because motor goals might be very different for a child who's functioning at level 5 than, say, for example, a child who's functioning at level 2. Did that answer your question, Kent, or did you have more questions?
For now, it certainly did. Yes, that was interesting.
Okay,
Thank
great.
you.
I guess one question that I have, having been reintroduced to various elements of this study with watching the presentation, I understand why there's an age limit and an age bracket for the purposes of the study, because you need to be able to follow it through and such. But is there any reason do we know if metformin and the effects of metformin could help with older patients with cerebral palsy? I can't remember if I knew that or not. So.
Yeah, we really don't have any information at all. And for the purpose of our study, exactly what you've just said, again, we're trying to minimize variation in the people that are involved in the study, because that makes it easier to detect a signal of metformin.
Okay.
But there's no reason to think that metformin might not work in adults with cerebral palsy as well. And so it's something that if we start to see a signal in this particular study, hopefully move to an even larger study, then this could be another study that could be set in the future. And we definitely know metformin is used in adults because a lot of people with diabetes take it. And Dr. Mabbott, I don't know if you have other added comments there in terms of adults.
Well, I was just going to say, like, in older adults, that's actually some of the literature that's shown improved memory and thinking abilities. There's a number of papers, actually, Josh, I could send them to you if you're interested. But there's no reason, perhaps the child's brain is more plastic right? Perhaps the stem cells in the child's brain are more amenable to metformin treatment, but other than that, there's really no reason why not to expect that we could move to adults of any kind of neurologic disorder. Typically what happens actually in a lot of clinical trials is it's done in adults and then we move it to kids. We're doing it the reverse because that's the group that we're working with. But I would agree with Darcy that this is it's frustrating because it's incremental, but it's incremental because we have to make sure we have all the best evidence. But I think a next trial could certainly expand the age ranges and expand the participants involved. You're always balancing on, we want to make sure we have a signal. We don't want to lose a signal because our group is too variable and then say it doesn't work when in fact it might work, right? So
yes, and I could see why it would be easier to track the changes in a younger, still developing group. However, when I was reminded of the potential memory benefits of the metformin, especially as someone with a learning disability,
yeah.
as a sort of a side effect of my brain injury caused by my CP, I was doing things earlier today with work that it would be very helpful if my memory and my speed of thinking was a little less infected, as I'm sure a lot of people would feel like. So it is something that sort of piqued my interest that would be in the future, and I can imagine that several of us would be interested in.
I think you've hit on the frustrating point for us as investigators, because we want to be able to say this is something that's you should be using and get it to as many people as possible, but it's that slow progress. I think Darcy knows this. Both of us have worked in this field for a reasonable amount of time, and we have to temper our excitement because we want to. This, I think, has some real benefits, and I think offers one of the few chances to really treat what has been previously considered like a long-standing kind of lifelong injury, and I think it always will be. Mm-hmm. But if we can start to have some mitigating impact, that's very, very exciting. But we have to
quality of life.
But we have to do the science.
It's true. It's true. Well, thank you. I was just interested and I'll be following it probably for the rest of my life. So keep me posted.
We will absolutely keep you posted.
You will be posted. You're part of our stakeholder committee.
Fair point.
Well, and my hope, Don, is that aside from the presumed benefits of a certain amount of pediatric neuroplasticity that you mentioned, I think part of the beneficial point of starting in a child and youth population is that hopefully then eventually we'll have a fairly robust sample to compare and contrast results of any follow-up studies in older populations, because I think that we sometimes presume that neuroplasticity is lost at ages when it might not be. So I would be interested to see how the results of this study will suggest the realm of possibilities for studies in older populations.
And in fact, the stem cell, it's less controversial, but I think it's still, I think it's fair to say the stem cell niches, those places in the brain that stem cells reside, there's evidence that those continue into adulthood. There's this idea of adult neurogenesis, for example, in the hippocampus, where even in adults, there is ongoing birth of new brain cells. So I think it's absolutely a fair point. And it's, you know, we have to go from the basic science and what we know there to the reality, you know, to the real world that people are living in. And that's, you know, we're kind of at the beginning of that process now.
Indeed. Excellent.
First question that we are getting quite often these days, understandably, is what are the precautions that are in place to ensure safety during the COVID-19 pandemic? So this is a short version of the answer to the question, because the answer essentially is many precautions are in place, both at home Bloorview and at Sick Kids. I think there's quite a lot of overlap between the procedures that are put in place. First thing is, before anybody is allowed into the premises of Holland Bloorview, they need to be screened. And I believe it's the same at Sick Kids. At Holland Bloorview, we have in-person screeners who actually will go through a list of questions, reviewing symptoms and exposure potentially to COVID-19 to make sure that it's as safe as possible for people to enter. And anybody who is experiencing any symptoms that are associated with COVID-19, or anybody who has come in contact with somebody that's known to have it, is not allowed in until it's safe to allow them in, which is usually a 2-week period at the very least. So we have those measures in place. While it makes it a little bit more difficult to get people into the door, I think it's absolutely essential to maintain the safety of both sites. Another precaution that's in place, obviously, is the use of masks. So everybody that comes into Holland Bloorview and Sick Kids has to be wearing a mask at all times if they are in a common area or within 2 meters of anybody else that's not in their bubble or in their family. We also have additional PPE requirements, so other personal protective equipment, things like gowns, shields, goggles, gloves, and those are required by all of the clinicians to be worn, and really for the protection of both the clinicians and the families who are taking part in the study. And they're quite extensive, and I know that there's additional hand sanitizer and PPE, other equipment all over the hospital, anywhere where we're going to be doing any study procedures. And I know that it's the same at Sick Kids. Third are social distancing protocols or physical distancing protocols. So anybody, just like in any public space, is not allowed to be within 2 meters of another person that's not in their family or in their social bubble. So that is obviously going to be the case at Sick Kids and at Holland Bloorview. And that's the case whether or not the person passes screening. So even if somebody passes screening, these protocols are still in place no matter what. Enhanced cleaning procedures and equipment sanitization. So if you walk around Sick Kids or Holland Bloorview these days, you'll notice the custodial staff is extremely hard at work, more so than ever before, cleaning surfaces multiple times a day, and as well as equipment. And the research teams are also responsible for making sure that once any equipment is used, so whether that's tables or chairs, computers, in our instance, physiotherapy equipment, and also at Sick Kids with their cognitive testing materials, everything needs to be sanitized before and after use, so that there's no risk of cross-contamination between participants. And then the last one I'll mention is just plexiglass barriers. So I know specifically at Sick Kids, for some of the cognitive testing that's done, masks get in the way of the testing itself. So instead, plexiglass barriers are used so that there's no exposure between the people who are doing the testing and the people and the participating families. So there are lots of precautions in place to ensure safety during the COVID-19 pandemic, and there's no plan to stop any of these precautions as long as it's still part of our daily lives. I realize I'm not in presenter mode, I can do that. Next question that we are often asked is, what is the time commitment for participation? So I won't get into too much detail about that, but basically we could break it down into 3 different sections of participation. So screening, which encompasses everything from when we get in touch with the families, whether they've reached out to us or whether we reach out to them to discuss the study, all the way through the chart review process and through the in-person screening visit. That's approximately 2 to 3 hours total. Once a participant is enrolled in the study, the first month of their participation is a little bit busier because the participants need to come to Holland Bloorview for physician visits once a week to make sure that everything is safe and that they're reacting well to the medication. So for that first month, it's approximately 10 hours total. There's a little bit of leeway there, depending on the individual and how quickly testing is able to be finished, but that's probably the average length of time is about 10 hours for that first month. After the first month, so from months 2 to 4 of when participants are actually taking the medication and receiving the physiotherapy, it's much less of a commitment than that. So it's approximately 6 to 7 hours per month. So that includes the study physician visits and the physiotherapy visits, and then our final visit to sick kids. So this again is an approximation, but does give families a little bit of an idea of the time that's involved to take part in the study. Next question that we are often asked is, are the physiotherapy sessions available after school and on weekends? So the answer to the first part of that question is yes, they are available after school. We are often running sessions anywhere between 3 and 6 p.m. Weekends depends on the weekend, so it depends on which day the families are requesting and which day our physiotherapists are available. But we are offering weekend sessions on a sort of need basis. So our preference, obviously, and the preference of the physiotherapy team is to try to do it on weekdays, but if we have to accommodate and do weekday sessions, we can make those accommodations. And just as a point to all of our scheduling questions, it's really determined by the family's availability and the physiotherapist availability in terms of when these sessions are done. So there's a little bit of back and forth between the study team and the families, but we do try to be as flexible as possible, and we understand that obviously for kids that are of school age, they're going to be in school most of the day, and the less school that we can miss, the better it is for everyone. And then I have one final question, and I will throw it over to Cynthia, because Cynthia is our coordinator at Sick Kids, who handles all the MRI aspects.
Great, thanks, Daniel. Hi, everybody who's eventually listening to this. So I guess one of the big questions that we get as well is, are the MRIs mandatory, and do they require sedation? The answer is the MRIs are not mandatory. However, it is sort of one of the key interesting pieces that we want to find is we want to see if there are any differences in the white matter in the brain as a result of metformin. However, sometimes children are not eligible to go in the MRI, and that's because of safety requirements. So MRI stands for magnetic resonance imaging. And so essentially the MRI is a giant magnet that the child goes in. So if they have any metal in their body or anything that precludes them from being able to go safely in the MRI, then they wouldn't be eligible. But if your child is not eligible for the MRI, you are still welcome to take part in the study. Sedation is not offered for the MRIs associated with this study. So if your child does need sedation for the MRIs, unfortunately then that's something that would make them ineligible for the MRI as well.